Morning, everybody. Thank you very much, Professor Kolesnik and Professor Tomalina. First of all, an apology that you have to have the headphones on and have to listen not to my real voice, but to someone else. I'm very sorry that I can't speak your own language, which is a shame for everyone from the UK. We are very bad at that. It's a pleasure to be back here, and it's a great congratulations to all of you for organising this first Congress. And I've become aware of how far many of you have travelled to come today and the next 2 days for this conference. And it's great that you've been able to take time out to listen to each other and to hear about how you practice and learn from others about how to do things to improve patient care. I'm also appreciating how hard you work indeed and how many patients you are managing, it's great that you've been able to take time out to come to this meeting. It's a great pleasure also to be my first time in Kiev and indeed in this part of the world. And I've learned already last night over dinner 3 things about Kiev. So just to get it's the most beautiful city. Ukrainian vodka is the best. There was a third one, which I've forgotten, but I think it may not be appropriate for a scientific congress, so I'll leave that one aside. And I do hope to be back here in at least 2012, when I can go down to that stadium just down there to watch England winning the Soccer European Championships. And who knows, we may be playing our old friends, the Germans, in the final. But I hope that also goes well. So it's a pleasure to be here. And as you can see from my first slide, I'm really coming from 2 countries. I now live and work in Switzerland, and it's great to see the Swiss flag there. But I'm originally from the UK and worked as a nephrologist in my last times in Wales for 10 years before moving to Baxter in 2007. So let's get started looking at PD and effective therapy for the future. It's interesting to remember that PD has been around for 30 years over now for regular treatment. But there are still things to learn, as we've heard from Ray, about the management of patients on PD. And there's still evidence of its effectiveness for patients in the future, as we've already heard from Professor Kolesnik with data from your own country. So hopefully what we'll do in the next half an hour or so is to explore some more recent evidence, perhaps, around clinical outcomes comparing PD and hemodialysis. We'll then explore some specific clinical benefits of PD as a choice of dialysis therapy. That's giving it particular advantages in particular patients. And then we'll look in a slightly different way at that by looking at certain specific patient groups, some challenging groups perhaps. We've already seen some data this morning about the diabetic patient who's on dialysis. First of all, survival. And let's just look at some recent data around survival of patients on PD and HD and transplantation. It's always very difficult and slightly challenging showing US data regarding patient survival, because sometimes we are concerned that their practice of hemodialysis in particular is perhaps less good than we think over this side of the Atlantic with our longer hours and perhaps even more frequency. But nevertheless, their data is very large because they have many patients and it's very complete. So we can be assured that we're looking at a data set that is large and full. And just looking over here on this left-hand side, we've got patients starting dialysis at different time points. These back in the back in the 90s, in the last decade, where we see that the survival of PD in the yellow is an early advantage over the early months of treatment, and then equivalence, and then maybe PD and HD are starting to separate again. But then looking in more recent times, patients starting at the start of the last decade and followed up for, well, 5 years, we can see that actually the early PD survival advantage is extending out, and there's equivalence now for 5 years, showing that actually PD can be an effective treatment for a long time for patients. And Ray's perhaps explained to us already some of the reasons for that, the appreciation of different ways of doing PD, cycle time, dwell time, and the use of different PD solutions, such as icodextrin, to prolong that time that PD is being effective and not requiring a transfer of patients. Of course, transplantation remains a survival advantage for those who can receive it, but we were talking over dinner last night regarding the challenges of all of our patients receiving a transplant and the low transplantation rates still in many countries. So looking at that a little further, and this slide looks very threatening, but we'll go through it slowly, well, what about different age groups? Is PD only good for some people and not for the elderly, only good for the young? Well, let's just have a look. So if we look at, again, 3 different time periods of patients starting dialysis, early 90s, early 2000s, and then the mid-2000s, and followed up, in this case, for 2 years. Again, data from the US, RDS, analysed by a group from Ireland. We can see that in the previous years, patients less than 50 did very well on PD. Patients over 70 didn't do so well. Their risk was increased compared to HD patients. But as we progress through the more recent time points, patients under 50 are doing better with PD, patients between 50 and 70 are doing better with PD, and patients over 70 are doing as well. So with improving practice, we've seen a better survival, even with the more elderly and therefore comorbid patient. And we see that progressively better survival in other parts of the world. So here are data from the other side of the world, in Australia and New Zealand, where they have a lot of home dialysis, PD and home HD. Half of patients are on a home therapy. And they're looking at patient survival over 5 years. Here are the data from the early 90s, and then we've got a progressive improvement in survival until the most recent data in the early 2000s, again followed up for 5 years. So things have improved, and survival with our knowledge of PD prescribing is improving. And coming back now to Europe, we've seen data from the US, we've seen data from Australia, but let's bring ourselves closer to home again and looking at the Dutch registry data. The benefits of having a good registry, good outcome data can't be overestimated. It's very powerful. So this is now mortality rate, so up is bad, and we've got HD in blue, PD in red, and this is time in months, again, up to 5 years. So the mortality rate is lower in PD for the first years until we get the equivalence with time here. So the message is common across different data sets. Okay. And it's interesting also, again, to bring it back to what's happening in the more overall group of patients that we're managing on dialysis. So here are data from the EDTA registry, and a collection of registries, the Dutch, the UK, part of Italy, Spain, Austria, Scandinavia, combined. And over time, over different years, just look at the men, we can see that the incidence is rising now in the 75 to 84 age group and the 85 plus. The other age groups have rather flattened out. Now, looking at the data that we saw this morning, it's obviously that in your country, perhaps, we're more down here on the curve and we're moving up. And as our patients get older, as our population gets older, as more dialysis is available, we'll be taking on older patients. And this is the real challenge for us as nephrologists, that as we get older, our patients are getting older too. And we're going to be faced with the challenge of managing the elderly as they start dialysis. And associated with that increasing age starting dialysis, though, we see improvements in terms of survival across Europe. So 1 year, 2 year, 5 year, and even 8 year survival is increasing with time. Despite more elderly, more sick patients, survival is increasing. And from these data from the EDTA registry, the risk of mortality has been reduced in PD more than it has in HD. So there are pleasant signs, good signs, that things are improving with outcomes on dialysis, with good clinical practice from clinicians such as yourselves. Okay. But what about these benefits of PD? If I'm saying there are some of those advantages, are there some specific advantages? So on our second point of our objectives. Well, Ray's mentioned the huge importance of preserving residual function. And we know, just very simply, that a patient on dialysis is much easier to manage if they're still passing a litre of urine. The fluid restriction is easier and their outcome seems to be improved. And indeed, this is PD, better survival with residual function compared to none. This is HD. Our HD patients, if they have residual function, they survive better than patients without. So it's true whether on PD or on HD, the survival advantage of maintaining this is important. Doing it on HD is a challenge. Ultra pure water, long, frequent dialysis are good factors. 3 times a week, large amounts of UF in a short time are almost certainly bad factors. But looking overall, what is it that preserves PD, preserves residual function most effectively? What factors are there in there that we can use to preserve residual function? Because it seems to be important. Well, here's data from a US study and showing that, losing residual function is associated with some racial factors. Preserving residual function using ACE inhibition, there's a surprise. We know it works from data in chronic kidney disease. Here's some association evidence that it can work in dialysis too. But the biggest factor in this study was that the PD patients were preserving more effectively than the HD patients. Continuous, no big UF rates, infrequently continuous UF, maintaining fluid balance. Okay, so that's important. What about this link with transplantation? Are there any benefits there? Not many data here, and it's a shame. It would be interesting to see more data linking dialysis practice and transplantation outcomes. But here are data from Spain showing that patients on PD receiving a transplant had more immediate graft function compared to those switching to transplant from hemodialysis. Is this a reflection of fluid balance? I remember in my own practice in transplantation, the anaesthetist wanted the patient dried out before that procedure. That might be great for the anaesthetist, but it's not so good for that poor graft that's going in and not receiving a great blood volume. Is that the factor? It'd be interesting to see more data. And what about infection? We've seen from the data from your own practice that infection is still a common cause of death in patients that are on dialysis. Well, what's the difference here between PD and HD? Well, in terms of looking at patients starting the two modalities over time, actually the percentage remaining infection-free over 12 months is no different between PD and HD. So actually the infection burden, the infection risk, is about the same, it would seem, from this study. But if you look at the kinds of infections that patients are getting, well, the PD patients are getting peritonitis, as we've seen already from your own data. But the patients with HD are not getting peritonitis, of course, but they're getting septicemia. And we all know the effects of septicemia on patient survival and long-term cardiovascular risk. And indeed, looking at that in terms of a hospitalization rate, again, data from the US RDS, the risk of septicemia and the amount of septicemia hospitalization in PD is staying the same, but in the US it's rising. Why is that? It's not hemodialysis itself, it's not the machinery or the water. Of course, it's the central lines and the use of central venous catheters, and the increasing dependency on that is what's driving that increased septicemia risk. And then, of course, we've already seen data from the Ukraine regarding bloodborne viruses. And of course, if we're not accessing the circulation, we can't spread and can't put the patients at risk of bloodborne virus transmission. So here are data from Turkey showing that the patients on PD are much less at risk of becoming hepatitis C positive compared to patients that are on hemodialysis. So there's another additional infection protection of avoiding an extracorporeal circuit. And here's a hot topic. You know, it's interesting when you stay in nephrology long enough, you see things come and go and come back again. Phosphate and calcium and PTH are one example. Hemoglobin is another. And we've seen the startling data, really, regarding the increased risk of mortality in the US with higher hemoglobins and the profit-driven drive to develop higher hemoglobins, which led to increased mortality. But the advantage of the PD patient, and we saw this morning from Professor Kulnisk already, is that the PD patient will need less EPO to achieve a higher hemoglobin in a natural way. Here are very recent data from the UK Renal Registry showing that hemoglobins achieved are the same, but the amount of EPO use is much less. That's less cost, and that's a benefit to the health system. And that in all age groups, actually, there were more patients in PD who were receiving no erythropoietin compared to hemodialysis. So from a health economic and possibly a survival benefit, these are good data. Okay, so we've seen overall survival. We've seen some specific benefits of PD. What about specific patient groups? Okay, here's the first specific patient group. This is the patient with obesity. And this is becoming a real problem. And if you just take a flight to certain parts of the world, increasingly the UK, of course the US, we see the massive amount of obesity that there is within the dialysis population as there is in the general population. What about this for patients on dialysis? Again, very recent data from the US RDS, analysed by a group in Ireland. 3 time periods again, 90s, 2000s, BMI categories, less than 20, 20 to 25. Kind of wish I was in that group, but I can't put myself in there. I can't yet put myself over 30, but we could go there. But look at this. Look over time, less patients under 20. Okay, that's good. We don't want our patients malnourished. But look, more patients over 30 in a BMI. So the distribution is changing. More obese patients. Okay. What about therefore survival, PD versus HD, in those different size groups. In the olden days, the obese had a risk if they were on PD compared to HD. But despite more of the obese now, actually survival, PD and HD is the same. So the practice has changed to take into account the obesity epidemic in the US, but we're actually achieving a good survival. So the obese patient can be placed on PD carefully, access can be a challenge, but the outcomes can still be good. And of course, with our prescription, we can have an impact on the weight change that the patient gets on dialysis. I don't know about your PD patients, but mine, particularly the ladies, used to be quite anxious about the weight gain, and particularly the weight gain around the trunk, which of course we know is associated with higher cardiovascular risk. So to reduce that would be important. We've had a hint from Ray that one aspect will be to reduce the glucose exposure. Well, does that work? Well, here are data from a study in Canada, apologies for the trade name of Extranil, looking at patients' glucose-only prescription, glucose plus icodextrin for the patients starting PD. The glucose-only patients gain weight, 2 kilograms on average. That's an average. Some patients are gaining more. Patients with a lower glucose exposure, no weight gain. So we can look at that and change our prescription. Here's another patient group that we could look at. I don't know in your practice, but how common is unplanned start? Patients who you don't know arrive needing dialysis quickly. In the UK practice, it was always a Friday afternoon. Just before you were about to go home for the weekend, you'd settled everything down, and the cardiologist or the diabetes doctor would ring up and say, just to let you know, we've got a patient with a creatinine of 700, you might want to come and see them. And you knew that was your weekend managing those patients. And in a lot of places, it's still a third of patients starting dialysis, maybe even a half, who start in an unplanned, less than ideal way, always with a central venous catheter. And we know if patients start that way, there are outcomes that aren't good. They have increased risk of death in the first 12 months, and indeed even longer. They have more hospitalization. They'd never receive a home dialysis therapy such as PD, and they have the infection risk of a central venous catheter. Is that always how it has to be done? Could the patients be managed differently? Well, here are data from Thierry Lobadet in Caen in France, where he has looked at patients starting as an unplanned start, but then educating them, informing them, and switching them quickly to peritoneal dialysis for those who wish. And he's looked at his unplanned start patients. 60 of his patients over 3 years were unplanned, and with this approach, by talking to patients, actually half of them switched quickly to peritoneal dialysis. What are the outcomes? Well, peritonitis rates, no different to his planned patients. Hospitalization, no different for his planned patients. And in terms of looking at survival over 3 years, actually PD as effective in hemo in terms of total patient survival. So it's possible with a system, with an approach, to even look at the unplanned. Another patient group would be the elderly. Specific challenges with dialyzing the elderly. Well, who are the elderly? My definition of elderly, of older, rises as I get older. So I'm 48 now. When I was 18, 48 was ancient. Now I'm 48, 65 is quite young. So it's variable. But in most places, this would be the patient over 70, over 75. But biologically, It could be someone much younger who has comorbidity, who has challenges. Everything's difficult. They've got other chronic diseases, lung disease, heart disease, arthritis. They're often poorly nourished, socially isolated, and they've often got hidden cognitive dysfunction. How about them for PD? Well, here are data from Edwina Brown from the North Thames dialysis study, showing that in a 12-month time study, elderly defined as over 70, that actually the survival rates, PD and HD, were identical. That the admission rates were identical, although there were more access-related hospitalizations with the HD group. So, yes, you can dialyse the elderly with PD as well as you can dialyse them with HD. Edwina has extended that to a more detailed examination of the elderly, looking at how they feel and how they are rather than their survival. And this is the BOLD study, just published in NDT, the first paper from the study published in NDT this year. And what she looked at was a matched pair. PD patient matched to an HD patient, same age, comorbidity, gender, etc., etc. In terms of anxiety and depression scores, using the HADS questionnaire, PD patients less anxious, less depressed. And in fact, it's interesting looking at the screening scores. There were several more patients on HD who were frankly clinically depressed than the patients on PD. So there was more depression and anxiety in the pairs who were on hemodialysis. What about how does the illness and its treatment intrude on your life? How bad do you feel because of your disease? So we've got PD, doing it every day yourself. That sounds quite challenging. But we've got hemo 3 times a week in an ambulance or a car to a dialysis unit. Quite a challenge. And actually, the PD patients said, we feel that the illness intrudes on us less than did the HD patients. So quite effective evidence for the benefits of PD in the elderly. And when you look at it all together, you come to this kind of conclusion, data from Canada and the US, where the physicians looked at all of their patients in the dialysis clinic, the pre-dialysis clinic, and said, are you suitable for PD? Could you have it medically, socially? And what they found was that actually, yeah, almost all patients can have HD, but almost 80% could have PD. Of course, unfortunately, currently, only half of the patients were fit enough to receive a transplant. So we've seen effectiveness in general terms. We've seen effectiveness for specific reasons, and we've seen effectiveness in specific patient groups, and most patients are suitable. But really, it's not a competition between PD and HD and transplantation. It's not a football match that someone's going to win. It's not that at all. Actually, all of those therapies are on the same team. They're all playing together, and as Ray has said, as our patient progresses with PD, as nephrologists, we've got to recognise the signs regarding transfer to HD. Similarly, the patient on hemodialysis may very much wish, after some time, to receive a home dialysis therapy with peritoneal dialysis. And we've got to be prepared to transition our patients between modalities as we can, bearing in mind our overall treatment aims of improving survival and allowing people to do whatever they want in their lives. I'm going to stop there. Thank you so much for your attention. I really wish the Congress all the best for the next 3 days. I'm only here for today and this evening, but I wish you well and congratulate all of the organisers who have worked so hard on putting such an excellent programme together. Thank you very much.